So for such a group of disruptive, transformational thinker leaders, it's really stunning that y'all finished on time. You have noticed that everyone in what looks like an audience is actually an expert who either could be or has been or will be on a panel. And the panelists are all, I've watched them learning from each other even as we've been talking. So as we take questions, but first I want to open up a little space between the five of you to offer you an opportunity to ask something of each other that has popped to significance. And I see Anna has a question. Do you? Or you're just leaning towards the microphone? Okay.
I can take the question.
Okay.
Sure, I have a question. So for Michelle, so I went to the School of Public Health at Bloomberg at Hopkins, and I'm just wondering how this new program has potentially changed the dialogue at the school about what is public health.
So thanks, Anna. That's such a great question. I'll share with you that and thank you so much, Gary, for saying we're disruptors, because absolutely, and even in the academic setting. So let me just say, I have my experiences in public health at the local level in Baltimore City and at the state level at the health department, running public health programs. So coming or transitioning to academia in 2017 was really difficult when it was very much I'm very much from practice, and I'm in a research space, and I'm trying to push practice and recognizing the importance of research. And so this program recognizes that individuals have to apply to the School of Public Health to get into the School of Public Health first to be able to qualify for the fellowship program. And the great thing is that the school leadership recognizes that and is willing to allow us to come up with, so the recommendations that you must have 2 years of health-related experience to apply. Well, if you are a lawyer or if you're in the fire department or a law enforcement person, you may not have those 2 years of required health-related experience. And so it's given us an opportunity to say, what is it that we're really thinking public health is, and how are we really looking to impact health if we are only looking for those individuals that have those 2 years of health-related experience. And so we have leeway in terms of looking at those individuals, in terms of looking at their applications, helping them to some degree with GRE and quantitative scores and taking classes before they even apply to be able to have them qualify for acceptance into the MPH program. It has allowed greater dialogue between the faculty to figure out, what are we doing? Like, the courses that I shared with you earlier are courses that we recognize, the school recognizes that we needed, and we had the financial support to create those courses and the support of the department and the chairs to be able to do that. So I think it's created a space for us to have opportunities to do things a little bit differently from a perspective of population and public health. Thank you for that.
Any other questions among the team? Let's go ahead to the experts on the other side of the table.
Thank you for a wonderful series of presentations and comments and remarks. And my name is Donna Grande. I'm the CEO of the American College of Preventive Medicine. Relatively new in my role, and continue to be interested in ensuring that the role of the preventive medicine doctor is also a part of the leadership dialogue and conversation as we think about building bridges between clinical and public health, community, and applications. And please, I think, Sagar, you mentioned a call to action as far as what I heard anyways, and my takeaway is that we have over 4,000 preventive medicine physicians and then residents in over 43 communities across the country, sitting many within medical colleges and or public health, schools of public health. And so these individuals may be part of your alliances and part of your efforts as you look at community-based change, as well as the way we can tap onto leadership in those domains of population health impacts. So I just wanted to offer that out, and then maybe any thoughts or feedback, or where there are case studies that you may not have presented anyways, where you are in fact working with some preventive medicine physicians, either in their role as health department officials and or officials in the corporate America that happen to be in your backyards.
So regarding joint call to action, yes, we have, this was an interesting effort, and Anna was one of the founding members of that joint call to action. It happened at the staff level. It was not like super formal, right? It was not like, yeah, there was no criteria to be part of this group, right? But I think at staff level, all these people were working together and decided why not we combine our effort and try to do something for our local members who would like to do the same thing. Since the group was formed, we have been having regular meetings, etc., and having a little bit challenge in terms of what the final goal or the long-term outcome should be. So that's why we will be going through the strategy planning session in this May. So all these groups will come together, and their communications and marketing people come together to talk about what we want to do with this group, how can we help our local members, what about other organizations. We don't have any transportation organization on the board, and we have seen interest from a lot of other organizations. So what are the criteria? We need to figure that out, and once we do that, I mean, we will have a better idea by end of summer of where the group is going, what is going to happen stuff. So I think I will definitely we will definitely reach out to you if we think. And regarding connection between I don't know, when you say preventive medicine doctor, do you mean hospitals or?
Preventive medicine has been around for about 60 years, and they're physicians that go through traditional medical students, right? So they go through their 4-year education, and then they do their clinical rotations, a year of clinical rotations and 2-year rotations through health departments predominantly. And so they come out of complete their residency program with not only the MD, but the MPH as well. So historically, they were about 75% of all health officers' positions, and that has changed over time as dynamics have changed and competencies and other assets that have changed at the state level. But some work in hospitals, but majority health departments, pharmaceutical, biolife sciences, medical devices, health information technology companies, health plans, payers. So they're working in population health in a number of different settings, and in academia as well.
Thank you. I just wanted to highlight an example from before working at AP. I was a student at doing my doctoral dissertation at University of Cincinnati, where we got a CDC project, Communities Putting Prevention to Work, where there were 9 community partners coming together to improve the health of the county. And the PI was Hamilton County Public Health, in which Cincinnati is located. But Cincinnati Children's Hospital, as you may guys know, is very good in terms of good reputation in terms of research, etc. So they were one of the critical partners, and they helped. It was amazing in terms of this was the first time I was working with physicians, with hospitals, etc. It was amazing in terms of the work, the feedback they brought about patients' experiences, etc. We helped them basically create like an app so that they can help they have counseling sessions as well as part of their job, so they can, especially for children who are suffering from severe obesity and asthma, to help them have a counseling session. So we provided them some spatial analysis GIS to help them locate healthy food stores, parks, etc., so that they can give information. They were really interested, and we applied for like NIH grant to identify like pharmacy deserts rather than food deserts, etc. We didn't get funded, but I think there's a good in terms of opportunity of collaboration. Another thing is health districts, like hospitals investing in the neighborhood in which they're located, so that they can improve. It's not only about emergency wards; it's also about surrounding neighborhood.
Thank you. Dr. Barnett?
So, terrific panel. Great information you folks shared. Sagar, a quick friendly amendment on your first slide.
Sure.
Important, you could discuss this with Dr. Gunderson, the important role of the faith community in helping Jon Snow actually connect the dots on these issues, thinking of non-traditional participants in the process. Each of you in different ways talked about change, the kind of change, the transformational change we're talking about, coming from these people that we're trying to give these special skills to be this master disruptors, right? But we're also grappling with some pretty fundamental structure and function challenges in organizations. My mindset now has for some time has been on hospitals, but Sagar and Anna in particular, are we just talking about all we need are individual disruptors in municipalities or county agencies? Or are there other changes that you think we need to be thinking about? What are the levers within these entities to achieve the kind of change we're talking about?
I'd love to hear Brian first.
Sure. Thank you, Anna. I appreciate that. Yeah. That's a great question, Kevin. And I think it's safe to say that we reject the model of individual heroic leadership. And we're grateful to our partners for helping us to come to that realization, Center for Creative Leadership in particular, and Leadership Learning Community. What we're building is collaborative leadership. And it's leadership that understands the need for broader frames and ways of communicating across our models or fields of understanding, but then, as importantly, deep engagement with communities. I think one of the things that's a common characteristic of many of the RWJ new leadership programs is this notion of community linkage as being critically important and community members as equal partners in the work. And so that's really about building collective efficacy and harnessing political power. I think that's where public health is going, and I think that's an ultimate goal of our leadership work, is to build collective power, and it necessitates collaborative leadership.
Terrific.
Thanks,
Thank
Brian.
Hi, Michael Ryan with the Institute for Public Health Innovation. And I have a question about the health in all policies language and framework. There's been some discussion about whether it's too public health centric. I'm just wondering, has it resonated with leaders and line staff and other agencies? Have you had to create like a broader framework around either equity or prosperous communities or whatever it is? I'm interested in how you've brought people into the vision.
Yeah, that's a really great question, because if you say health in all policies, people just sort of, and then you say, oh, sometimes you give examples and they say, oh, we're already doing that. We are, the new way of planning is to always have sidewalks. So we already do health. So yes, and social determinants of health is also not like usually a headline either. So we are continuing to refine and work on the messaging, and actually we haven't figured it out yet. So I'll come back to you like in a few weeks. But one of the things that has helped gain some momentum, at least in Fairfax, is the conversation around equity. And we actually have a one Fairfax policy that was adopted in 2017 collaboratively between our board of supervisors and our school board. At the same time, they adopted the same policy. And that policy requires the consideration of equity, of an equity lens when doing work, policymaking, project development, et cetera, across the county. And I'm part of a team working with the chief equity officer to actually figure out what that is, operationalize that. But the other thing in regard to how do we make health and all policies relevant across county agencies is actually just to speak in the language of those agencies. So having a planning and transportation background is very helpful to this role. So when I talk to people in planning, for example, the recent desktop HIA I did on this large development, I didn't actually outline the topics as health topics. I outlined it in the same way that the planners are talking about their work. So I had a section on transportation and I had a section on land use. And in that, I described the link between health and transportation, the link between health and land use, and then talked about the specifics of that project. But when I had a colleague look at it, she said, oh, well, I don't see active living. Where's active living? And I said, well, the planners don't know what active living is or what physical activity. They don't care about that. They think that's an individual thing that you have to take care of on your own. So you really have to flip it, the public health language, and really try to meet them where they're at.
So I would observe that we've created an appetite for more participatory part of our dialogue, and I can promise you that's what's coming next with the leadership of my colleague, Dr. Martha Gold. We're going to bring this part to a close, sort of call and response part of this, and move toward participatory. I want to thank the panel so much for setting this table.